Welcome to Resilient Waters, Healing in the 10,000 Lakes. I'm Amy. Let's get connected. For today's episode, I am so grateful to be able to introduce you all to Dr. Kotatee Tamba. Dr. Tamba is a clinical psychologist at the Clinic for Attention, Learning, and Memory, CALM, where he specializes in administering and interpreting neurocognitive assessments and providing coaching to both clients and their families. He is an approved supervisor by the Minnesota Board of Social Work and the Minnesota Board of Behavioral Health and Therapy. With over 8 years of experience as a therapist, Dr. Tamba has worked with individuals of all ages, focusing on psychoeducation and the personalization of therapeutic services. He is committed to helping individuals and families achieve optimal functioning by fostering emotional, relational, and developmental growth. Hi, Dr. Tamba. Thank you so much for joining me today. I've been really looking forward to our conversation because I feel like your specialty area is a very needed, also hot button topic. So I'm excited for people to get some more information and maybe get grounded into maybe some of the newest information about working with people with ADHD specifically in testing. So thank you. Welcome.
Absolutely. It's wonderful to be here, and I look forward to sharing some of the information we know and then answering some of your questions.
Perfect. Well, let's just start with the basics of how did you come to your current clinical focus?
Well, it was a really, really long story. So I graduated from the University of Minnesota with an undergrad in psychology and sociology. So I've always been really, really interested in how the cognitive aspects are impacted by the social factors. So I did a double major in psychology and sociology. And then after that, I went to graduate school at Minnesota State University in Mankato, where I did a master's in social work and then worked on becoming a therapist. So I did in-home therapy. I did, and then from there I progressed. I became the clinical director of Goodhue County for Fenbrook Family Center. So I did a lot of that, so supervising master's level students and also doing therapy. And then I got a report from the CALM clinic, and this report was very, very detailed. I was like, wow, this really, really helps me understand this client and the family. And then I went to LinkedIn and then followed Dr. Johnson, who is the clinical director at CALM. And then a year later, I was like, maybe I should go back to school, And then I went back to school to do my doctorate. So I then did my doctorate in clinical psychology, did my internship at the CALM clinic, and now I work at the CALM clinic as a clinical psychologist. So that's how I got from being a therapist to now being a psychologist. So in my work, I try to integrate my social work training, my training with work being a therapist, and then integrating that as part of being a psychologist. So
I love it. And as you were talking about, as we start these careers, we just have this genuine curiosity about things, and it just leads down this path of trying to figure out what's going to help people the best. And it's interesting as you talk about that, I'm like, I wonder if our paths have crossed before, because I went to school to Mankato too.
Yes,
I had to spend 6 years down there. So, and when you find someone like Dr. Johnson, who is specialized in something that's just fascinating, also really helpful for people, it's hard not to just be attracted to wanna to join that, club there. I have to say, as a clinician, one of the main reasons why I wanted to reach out to you guys and do an episode is, yes, you guys do great work at CALM. Your thoroughness in your testing and the attention to detail that you have with people, I have noticed over the years. And so I just really appreciate that. And I'm excited for people to hear more about how that works and looks. So if they need to get hooked up to that too. So that's really, it's fascinating. Thank you for sharing.
Absolutely. So yeah, I mean, my time at Calm has been wonderful. I've learned a lot. And I think one thing that really drew me to Calm is focusing on the individual experience. Yes, we have a number of different batteries or different assessment tools, but every person that comes through Calm gets an individualized like concoction of what that looks like because we're looking at why is this person coming in, and we're always adjusting as we go along. So after the first day of testing, we meet as a team and we're talking about yes, what we're seeing, yes, the data. Okay, what do we need to do next? Do we need what we're noticing this? Let's add that. Let's right. So I think we're always solving puzzles. And Dr. Johnson said this all the time is that what makes our job really, really fun is that we're trying to connect these different and complex pieces and these different complex puzzles. So
I love that. And I think your background just speaks volumes to that. People are complex, just
yeah,
individually, but also in groups. And that
right.
sociology background probably really helps to the social work background because
Yes.
relationships and environment play a factor in all of these things. So I love how comprehensive it is. So let's talk a little bit about, for those who are listening, right? Who do you serve? What types of clients walk through your door? Who do you specialize with?
So we do the whole gamut of things, but our specialty tends to be around attention, focus, concentration, and learning. So if you look at our clientele, about 90, I would say 80 to 90% of individuals we work with has been misdiagnosed.
Yeah.
So what that means is that they got a diagnosis that they shouldn't have gotten, or they should have been diagnosed with something but didn't get that. And then what we do is we come in and we look at these very, very complex presentations and we try to tease apart what is going on, looking at cognitive impact, we look at intelligence, we look at executive functioning, we're looking at a social acuity, we're looking at mental rigidity, we're looking at memory. We'll also do some tests that looks at the auditory processing, and then we do a full personality assessment as part of that process. And what we're doing is that we're looking at every possible facet and we're taking any additional information. We're looking at the medical history and we take that as a whole and then we're looking for patterns. And I think what differentiates Calm from other places is that we then take all of that information, we're looking at the most updated research to provide an individualized recommendation. And our goal, don't get me wrong, a diagnosis is important.
Yeah.
But what we try to focus on is that we try to focus on interventions, right? Because anxiety can have several different presentations. Depression can have several different presentations. ADHD can have several different presentations.
Yeah.
And then what we try to say is to say, here is your experience of this, and here are some individualized recommendations to help you manage your symptoms. So if it is a person in school, we're looking at educational recommendations, we're looking at nutrition, we're looking at cognitive strategies, we're looking at emotional regulation strategies, we're looking at behavior interventions, we're looking at environmental adjustments. So we're looking at all of these different facets to be able to provide a holistic approach.
That's what I want to shout to the rooftops is something stuck with me the last time we spoke where you talked about how you're giving recommendations based off the symptoms, not just the diagnosis. So someone comes in and they don't meet a full DSM diagnosis, you're still going to give recommendations on what could be helpful for the symptoms that they came in the door with of, maybe attention or learning or memory and helping get relief in whatever way is possible. I just think that is so helpful. The list, when I've worked with you guys and I've gotten a report for someone who's getting clarification or extra services from you, is that list of treatment goals and recommendations are so thorough and so helpful and also attainable. Like these are things that people actually can do something with. And when they read it, they understand it just as much as I can understand it from a therapist aspect most of the time. And it's probably because you've gone over all those recommendations
Right. Thank
so thoroughly with them, and I'm so
Mhm.
appreciative of that. It's
Mhm.
top-notch care. I love that.
Mhm.
Thank you.
And absolutely. And that's what the battle it becomes is then how do you write, or how do you present information in a way that is easily digestible for the client, but also can be digested by therapist, school, right? And then separating recommendations into separate sessions. So for school, yeah, yes, what you need. For home, yes, what it is that's going to help. For in your work with your therapist, yes, what's going to help you. Yes, some things we want a therapist to focus on. It might be emotional dysregulation. Yes, how you go about working that based on the personality profile, or if it's a person that is diagnosed with ADHD and anxiety, right? Well, yes, how the anxiety is impacting the ADHD, and yes, how the ADHD is impacting the anxiety. Well, if you're working with a therapist, learning about those two and the impact would be really, really helpful. So those are the recommendations we're making so that it provides a roadmap for providers, but it also provides some really, really good information to the client so that they too can understand, like, yes, how everything is interconnected.
Yes.
Yeah.
Yes. It's fascinating. And I want to add in there too, just because I've had the privilege of working with you guys enough that I also want to let people know that when it comes to trying to differentiate between diagnoses like PTSD, because I work with a lot of PTSD, right? And anxiety and attention issues, like this is a great way to get more information about that. And I love the fact that you guys very much acknowledge that piece as well, because oftentimes it's very difficult to determine what's maybe a PTSD symptom versus an ADHD symptom, and or
Absolutely.
both.
Yeah, and I think the latter part of that is like it can be when we're looking at things, we're looking at is it ADHD? Is it depression? Is it PTSD? Is it PTSD, ADHD, and depression, and
Yes,
how are they connected, right? So we have to tease those pieces apart while trying to understand the interconnections between them and then try to differentiate, right? So differential diagnosis for us is really, really, really important and try to understand that. But like you referenced something earlier, yes, we might not give a specific diagnosis, but we still give recommendations to manage the symptoms. Because when we look at the DSM-5, right, when you're checking these boxes, what if if the person needs 6 out of 10 different categories, right? And it's okay, the person only got 4. Well, what do you say to that person? Good luck. Good luck with the
right.
4. Let's have fun with that, right? No, we still have to say, nope, these 4 different symptoms, yes, you didn't meet the diagnostic criteria, but these 4 symptoms are impacting
Yes,
you on a daily basis, and how you go about managing those.
yes. It, it
Yeah.
it is so difficult sometimes, and with an office like yours that takes the time to really look at that and make those
Mhm.
recommendations, it's wonderful because otherwise the experience is, oh, check, you don't meet that box. Good luck. Right.
Mhm.
And that's
Mhm.
sometimes what the system has set up in the past. And so it's such a different experience when you're working with a clinic like yours who can
Yeah.
really take the time and energy to clearly communicate all of the intricacies of our field, because that's the
Mhm.
reality, right? It's not an
Yeah.
easy system sometimes to manage
Mhm.
on our end. And so
Yeah.
I very much appreciate that. I wanted to give a
Yep.
little bit of time because you had talked about um, there's some newer information out there on some overlooked aspects of ADHD that you wanted
Mhm.
to give some time to today. Do you want to talk a
Mhm.
little bit about that?
Yeah, I mean, one of the things we're seeing is that when we look at the DSM-5 or we look at how ADHD is described, there's some primary things we tend to focus on. Typically, a lot about just inattention and hyperactivity. But when we really look at the history of ADHD, when ADHD was first discussed as a disorder, right? What we saw is that there was a lot of emphasis on the emotional components of ADHD.
Yes.
However, when we look at the early research was done on adolescent boys who were often of middle class, from middle class families. And their symptoms is what was used to describe what we now know as ADHD. But what that has done is that there have been a lot of symptoms and a lot of other presentations that have been overlooked. So one thing we started seeing in our research and in the presentations we do is that the emotional components of ADHD is often overlooked. But for a vast majority of people, about 80% of individuals that are diagnosed with ADHD actually describe emotional dysregulation or sensitivity to rejection as being some of the most influential and impactful pieces. But because those pieces were dropped in the 1960s, what happened is that research dropped, insurance dropped, interventions dropped, the way it was conceptualized dropped, and the way we are taught to manage and to work with ADHD from an emotional component also dropped.
Yeah.
What that has done is that people are reporting these symptoms as being very, very impactful, but there's nowhere in our literature, nowhere in our interventions that addresses that. So one thing we've been trying to be mindful of is emotional dysregulation, just struggle with controlling emotion, which can lead to intense feeling of anger, irritability, and sadness, and then rejection sensitivity. And what we like to talk about rejection sensitivity is not so much about an actual rejection, it's about the way the person thinks, right? So the person tends to be more anticipatory.
Yes.
So when that person anticipates, then what we know about the brain is that our brain struggles with differentiating things where we're imagining from things that are actually going on in real life. So if that person is anticipating being rejected, they are going to react and respond preemptively, right? And what that does, it creates this recurring cycle. And this is how then ADHD can also then lead to intensified anxiety-related symptoms. And it also then impacts our relationships and our interactions with other people. So two often overlooked aspects are the emotional dysregulation that comes with ADHD and the increased related symptoms of rejection sensitivity.
That makes so much sense to me. I think so much about, because again, my specialty area is trauma. And so I think about the developmental pieces of the brain. And when you're talking about someone who already has maybe ADHD and then they get to adolescence, and that is a very difficult time because it's all about needing to belong. It's not a want, it's a need at that point in our development. And with the rejection sensitivity on top of that, they're going to experience trauma. It's I don't know about you if your experience is also, it's very difficult to work with someone who has ADHD or to find someone who has ADHD who has no trauma, because they typically go hand in hand because of a lot of the differences and the struggles that come along with the development.
And what we also see from the research is that if a person has an ADHD diagnosis, there's a higher prevalence that that person will also experience PTSD, or they will be traumatized, or they're more likely to become the victim of some form of abuse, all of that, right? Because, again, sometimes they might not be as aware, they might not be socially attuned because they're distracted, or they might do things that might agitate or irritate other people, and then people are responding and retaliating. So, right, but they tend to experience higher prevalence of trauma also.
Yeah, I talk so often with people just about the fact that whatever diagnosis, but that specific age point in adolescence, if that belonging need isn't met, it is a huge attachment trauma, and it's very difficult for people. And we don't really acknowledge that very often in our world, that was a need. So fascinating.
And so those would be the first two pieces. And then another piece that I think is often overlooked is a lot of times when we think about ADHD, even the name attention deficit hyperactive disorder. For me personally, I do not like the name. Right. I think it should be called variable attention disorder, because when you say attention deficit, it's almost like the person is unable to pay attention. But what we're seeing from the research and from our work is that individuals with ADHD can actually pay attention. if something is interesting
Yes.
and engaging,
Yes.
right? When it's boring, repetitive, or mundane, is where the person then struggles. And a vast majority of times, individuals with ADHD can actually really can hyper focus on prefer activities.
Yeah, I was wondering about that because that seems to be something I notice at times too. And then
Yeah,
you wonder, is it more ADHD or autism spectrum
right.
symptoms, right? And so those tend to sometimes have overlapping symptoms. Is that one of them?
Yes. Yep.
Okay.
Nope. That so ADHD loves company, right? So
Right.
another piece that is often overlooked is comorbidity. What we tend to see, um, ADHD tends to be harder comorbid with autistic spectrum disorder. It also tends to be harder comorbid with different learning disorder, specifically dyslexia, dysgraphia, dyscalculia. So right, out of those, we
Ah,
also tend to see that it also tends to be harder comorbid with depression and anxiety. And we also tend to see it tends to be highly comorbid with ODD, oppositional
yeah.
defiant disorder. But what we're seeing from the research too is that when we really look at oppositional defiant, a vast majority of the times, people are being misdiagnosed as
Yeah.
being oppositional
Right.
when they're actually very hyperactive and inattentive.
Yeah. It kind of brings you back to that first point, right? That
Mhm.
that overlooked aspect of emotional regulation
Yes.
for
Yep.
ODD instead.
Mhm. And when you look at a person that is emotionally dysregulated and you're asking them to engage in a boring, repetitive, or mundane task that the person is anticipating they're not going to do well,
Yeah.
it's easier to say, I'm not going to do that by being oppositional than to actually have to go through that and not do it successfully.
As you say that, I feel that for so many people that
Uh-huh.
that is such a fact in their life that they would go, oh, somebody actually sees and hears what I've had to
Yes.
experience.
So, so if and I've gone to schools, I've talked to parents, I was like, no, Johnny, a Sarah, a Beth isn't oppositional. This person is anticipating failure. And it's easy to say, nope, I'm not going to do that. And to say, yes, let me do this and not do so well. And then have to think about that and sit with that emotionally.
So
Hmm.
overwhelming for so
Hmm.
many.
Yes. So again, when we're working through stuff, is just trying to understand when do these symptoms typically occur? What are the contexts? What tends to trigger it? How long does it last? What tends to be the recovery process? So we're trying to tease all those pieces apart because again, if we're just looking at the surface level, you can see one thing. If you just look beneath the surface, you try to tease those pieces apart.
Yeah.
Mm-hmm.
Such great information.
Mm-hmm. Mm-hmm. And then another piece, and then when we look at just the whole facet of like time blindness, the inability to estimate how much time it takes to get something done. I don't think we really understand how impactful that is.
Right.
The ability to estimate how much time it takes to get something done is by far one of the most influential aspects of leading a successful life. Now, and when I work with families, what I tend to talk about is that just imagine if you are always either underestimating or overestimating time.
So,
What that does to your psyche, what that does to you emotionally. But time blindness tends to be one of the most impairing pieces. And what that does is that it impacts the ability to plan effectively. It
right.
impacts procrastination. It impacts emotional awareness. It impacts just trust within yourself. It impacts your relationship with other people.
Yes.
And that's a piece that we tend to often overlook when it comes to ADHD, just that time estimation piece. It tends to be really, really off. Typically, it tends to underestimate.
Right.
So they'll say, oh, it's going to take 5 minutes, when in reality, it takes 15.
Yeah.
Right. But that's 10 minutes that was not accounted for. That's 10 minutes that was not planned for. That's 10 minutes that someone else is going to be waiting. That's 10 minutes this person is showing up late to something. Right. So then
Yeah.
it just has that domino effect over the entire day and over the person's entire life.
Right. I
Mhm.
think about the added stress that causes as we're
Yep.
recording, it's like holiday season for so many people. And I
Right.
just think, oh my goodness,
Mhm.
how stressful for
Mhm.
so many who are dealing
Mhm.
with that and not even realizing that's a piece of
Mhm.
this possible diagnosis or a symptom that's very difficult for many
Yes.
because it's
Yeah.
not talked about.
Yeah. Yeah. And that's a piece that's very, very important. And another piece that I think is often overlooked is when we talk about the masking of the symptoms. People tend to mask the symptoms. So they're trying to find different ways that to fit societal norms. And we tend to see this more in women and girls because, right, there's societal expectations on this is what life should look like. And one book I'm actually reading right
Oh,
now, understanding the girl with ADHD, and what I think is so impactful is talking about how the symptoms looks completely different and what that looks like. But I think even now, as we're starting to make advances as a field, we're noticing that women and girls are being diagnosed later because the symptoms looks a lot different. The symptoms tends to be more inattentive than hyperactive. So there tends to be a lot of daydreaming. There tends to be a lot of like, right, just overthinking. But none of that is visible.
no.
You can literally sit and be 20 miles away and no one ever knows that, right? Right? So
Right.
when we see a lot of symptoms, right? But again, as a clinic and as a field, these are the advances we have to make to be able to serve everybody.
It's so fascinating because, yeah, like you said, a lot of the research originally was done around adolescent males and middle
Mhm.
class. And so
Mhm.
now we've got all this information. We're really looking back in a lot of this research.
Mhm.
I'm thrilled about that. I'm also
Mhm.
curious to see how that's going to play out over time.
Yes. Yeah.
Um, and and how maybe our system might need to adjust a little bit
Mhm.
to bring in more information for people and get some more accurate diagnoses.
Mhm.
Um, I as For anyone who is listening to this, please note I will continue to list all the resources that we reference and talk about today at the
Mhm.
bottom of the episode during in the notes. So if
Mhm.
you didn't catch that book, don't worry. I'll reference it again later. You can take a look because I know that's definitely now going to be on my reading list.
Mhm. Well, it's just fascinating, right? But again, right, those are the pieces that we're looking at. So when you going back to the clients we serve, right? So about 80% tends to be um have been misdiagnosed. So typically our breakdown tends to be about 33% children, 33% adolescents and above, right? And then 32% adults, right? But say I don't know how it happens, there's this perfect breakdown. So we tend to see people across the spectrum. But again, when we're looking at those pieces, we're trying to look at, okay, what does that presentation look like for a child? What does that presentation look like for an adolescent that might be going through some life transitions, hormonal changes? And that's another area where when you look at the impact of hormonal changes and how it impacts attention, focus, and concentration, we can literally talk about that for months, right?
Right.
Because there's just a lot there, right? And then we'll look at as the person ages, what does that presentation looks like? So when we look at these different facets, we're trying to look at the individual pieces and the differences that occurs as we progress developmentally, as we change developmentally.
Right. That
Mm-hmm.
developmental piece is so important. And I
Mm-hmm.
love hearing that we take the time to think about the different hormonal changes because there's
Yeah.
so much and that does look differently for girls versus boys and things like that, men versus women. And so
Mm-hmm.
it'll be very interesting to see
Mm-hmm.
some of that
And
research.
absolutely. And what we're seeing too is that, especially for females that are going through perimenopause,
Hmm.
right? So for some of these individuals, they have been very, very successful. They have been able to just hold it together just because they have created some wonderful systems that helps them. And then they get to that stage of their life and everything just comes like crumbling down. And the person's like, well, but these symptoms have always been, but I've just done a really, really good job holding it together and then seeking answers. But again, it's then looking at, again, what was life like? What were some of the protective factors that you had in place that were helping you just go through, and
Yeah.
then what are the other factors now that are really, really impacting on understanding what that process looks like.
Is that part of the masking that you were talking about that oftentimes
Yes.
women do? It's part of that resource of how they manage with the symptoms and still
Yes.
participate.
And one question we ask that is very transformative is, on average, how long or how much extra time do you tend to spend doing things that typically takes other people this amount of time? And what you see is that person is at work at 7 p.m. when everybody else left at 4 p.m. or 5 p.m. And this person is working to 7 or 8, or they might come home, get everything else done, and then work extra. Why? But that person does a really, really good job. At the end of the day, everybody is like, oh my goodness, you got it done. But what people are not thinking of is like, how much extra time did it take you to get that done, right? Did you have to work on the weekends? What does that look like? And so it's taking out of these other facets. And one thing we're also saying is that some of these individuals are highly intelligent. So this is not an intelligence issue, right? It's an attention issue. And what we see is that one of the testing we do at COM is we do a full intelligence test.
Yeah.
A purpose why we do that is we're looking at differences within the person's intelligence profile and how that aligns with the presentation of ADHD.
Yeah.
And what we learn is that there'll be a vast majority of the times where the person is functioning at or above the average level for most people. But that person could have been even higher.
Right.
And when we look at that person and say, oh my goodness, in comparison to the average person, you are doing fine. When in reality, that person could be, but this is where then the depression piece kicks in, because that person keeps saying to themselves, I know I know I can do better. I know I should do better. Right? But it takes so much more time. And one thing we try to look at is then we look at processing speed. How fast does it take you to get things done without making a lot of mistakes? And what does that look like? Because sometimes people tend to sacrifice accuracy for speed, or to sacrifice speed to be accurate.
Right.
So it takes them longer to get something done, but to do a really good job. Or if that person just wants to go fast, they'll make a lot of careless mistakes. It's always trying to find that balance.
Right. And a lot of that is masking and trying to compensate for that piece that no one else seems to be acknowledging. I think back to so many different people that I've worked with or known who have gone through some of this, and it's well, Johnny can do wonderful. They're very bright. I just don't know why they don't do X, Y, or Z, or they can't shift from one thing to the next, or whatever it is. And I feel like that's, if you go back to people's report cards, I feel like you're going to see that message over and over.
And when we look, there's been higher prevalence of like people being diagnosed later in life. And part of the reason why that is that it wasn't that these symptoms were not there. They have always been there, but the person have either done a really good job masking them, or they have implemented some systems that was helpful. And what we see is that as the person progresses through the career or through school, the symptoms tend to be more intense, right? So if you look at high school or elementary, so in elementary, you get a lot of one-on-one help. And you go to middle school, you still get some help, but the teacher now expects you to be able to track your different classes and all of that. That bump for people, you'll notice an increased level of symptoms. Let's say if the person still did a very good job in middle school, to jump to high school, the demand shifts. Right? And then you go from high school, you jump to college. Now you're expected to show up for your class on Friday at 3 p.m. Right? That's a different story as compared to high school, where it's like you are from this time to be in class, right? So again, and then that person leaves college and starts to work. That's another jump. You're now expected to perform. So it seems that as we go through these major life transitions, it can also be really, really helpful. It can also be really, really impacting.
Is it difficult for those who didn't get a diagnosis younger in life to get a diagnosis, or to kind of check all the boxes for a true diagnosis later?
So what we do is then we're looking at historical data, and we ask some questions around early life experiences to see what that look like, and then we're taking the updated information. So it's a combination of all of that to try to piece those pieces apart and taking really, really good developmental history.
Yeah.
What did life look like growing up? What were your symptoms like? What did it right? So we're taking all those pieces that often you can collect a very, very good history and maybe getting information from parents and caregivers and looking at report cards and looking at all of that extra information. It actually helps bridge the gap. But most instances, people will always say, these symptoms have always been present, but here's how I've been able to cope with it. Here's
Right.
here's how I've been able to manage them.
Yeah.
Yeah.
Oh, such great information. I want to make sure that we get to some of the questions too, because
Good.
I'm sure there's going to be people who are listening to this going, yep, yep, yep.
Listen.
How do I get some of this, resource for myself?
Listen.
So, what does that look like for prospective clients, like coming through the door for you?
What we do, we typically we tend to have a really, really fast turnaround. So the first point of reference, the first point of interaction will be contacting our office managers, Mercy or Claire. They typically do a wonderful job, right? Just coordinating and we like to say they are an extension of our executive functioning, right?
Yeah.
So they will then take inquiry, get things set up, and then they will send you information. So typically the typical client that goes through CALM, first we do an intake. Doing an intake, we get all of your information just to see if it's going to be a good fit, to see what your symptoms looks like. And then based upon that, we just schedule 2 to 3 days of testing.
Okay.
Each testing block is between 3 to 3.5 hours. So on average, you're getting 6 to 10 hours of testing. And then after you're done with that, so we're looking at everything. We're looking at everything. And after we're done with that, we then do a feedback. So the feedback is done to talk about all of the data, to talk about how the person did overall, to talk about what that means, to talk about diagnosis. So we'll go ahead and do all of that. And then the persons then get a copy of the report, and it will want you to implement the different recommendations for 3 months. And then after 3 months, we do a 3 months follow-up. So during that time, we're meeting and say, okay, it has been 3 months. What has life been like? What has helped? What hasn't helped? What do we need to adjust? And then it gives us feedback to make adjustments as needed.
I love how thoughtful you guys are on this process, because it is about, getting all that information, but also making sure to give the feedback, getting recommendations, and then following through with those recommendations later. It's a very different process than maybe I've seen with other places. And so I really appreciate that.
Yeah, and that's all due to Dr. Johnson. He has done a wonderful job of formulating, and we're always taking feedback. So at the end of, so we usually have a lot of doctoral level students, and I'll be honest, without them, we won't be able to do what we're doing because they do a vast majority of the work, but again, we're working together as a team. But then what we also do at the end of every school year, we're meeting with them and talking about what are some changes that we as a clinic need to do, right?
Yeah.
What are some things we need to adjust? What are some recommendations that you saw over the past year that you think would be really helpful for us to research and to learn more about? So we're always trying to stay up to date. And something we do at the clinic too, at times we will go and do presentations at different agencies. We do MACMA, we do the Minnesota Psychological Association. We've done for different school districts. We've done presentations for different organizations. And what this also does, it keeps us up to date, right?
Yeah.
Information, because for you to be able to competently present information, you have to really, really know about it. And what that does, it just keeps us updated. And one of the presentations we do at MACMA, which is the largest children mental health organization, is that we do the ADHD update. So what we do, we track all of the research over the past year on ADHD, and we provide a presentation in a way that is more digestible to anybody.
I love that. I know you were talking to me about this before. It's in Duluth, which is really cool.
Yes, no, it's in Duluth.
It's accessible for a lot of us.
Yeah, 3 to 4 days of like just awesomeness.
That's It's so helpful. And
Yeah.
it's
Yes.
so great to know that we continue to research and that you guys here are continuing to
Mhm.
research and build the information and
Mhm.
better the services that are offered to people. It's just
Mhm.
phenomenal to have that local.
Absolutely. It's such a wonderful resource. And then we have done a lot of work with them, and they do a fantastic job just just providing a one-stop shop for providers
Yeah.
and parents. So,
Yeah, that's wonderful to know that parents are welcome
mhm,
to be involved and be able to hear a lot of this information. Because again, if you're working with a child that is maybe dealing with some of these symptoms,
mhm,
hey, here's the latest and greatest
mhm,
right here
mhm,
available to you. So
mhm.
it's fantastic. Okay, so do you guys have openings? What does that look like? What's
So typically, Mercy and Claire manages that. I think at some point, so I don't know the up-to-date information. I should know this, but I
That's
don't right
okay.
now. So typically, I think it's about, we had a waiting list, but now it's down to like, it's less than 3 months, the
Okay.
turnaround, right? So we're moving things, but Mercy and Claire manages all of that. So if you call them and you're like, this is what is going on. We had a family about 3 weeks ago that was like, we need to get this done by December, but again, we have some flexibility. We won't always be able to do that, but in this scenario, we were able to make adjustment. We will be able to get that family in, get it done by the end of December. Again, that is not typical, but we try to be very, very flexible. So I said, contact Mercy and Claire. They
Yeah.
have a wealth of information, and even if we're not able to um, accommodate the person at that point in time, we would also then provide some additional resources that can be really helpful for that individual and their family.
Right. Because
Mhm.
yeah, that changes throughout the year. I'm sure that there's also times a year where you get more flooded, maybe
Yes.
school times, things like that,
Mhm.
bring some cycles with those things. So a little bit
Yes.
of flexibility, but knowing that hopefully within a couple, you'll get information right away
Yes, you get
from,
information right away, and typically it's less than 6 months.
got it.
So,
That's
yeah.
good to know.
I'll
Now,
say
I
three.
know there's information on the website about like payment and insurance information. You want to talk a little bit
Yes.
about that?
So most we take Blue Cross Blue Shields. We also take medical assistance as part of Blue Cross Blue Shields.
Okay.
Um, but if a family doesn't have Blue Cross Blue Shield, we can also provide an itemized receipt for the person to take to the insurance provider to be able to get reimbursed. So we provide both of those.
Yeah, I think a lot of people don't know about
Mhm.
that piece of it. That if your insurance isn't taken by a certain clinic or things like that, that you
Mhm.
can request an itemized list of
Yes.
that information,
Mhm.
and then it'll be an out of network, but
Yes.
it's
Yeah.
still very helpful, and
Mhm.
you can get some of those benefits back. So
Mhm.
that's huge.
So we do that, and we also try to give back to the community. So every student that goes through COM, we have them do one pro bono case. So at the end of the year, we then look at some families that we may not have been able to serve, some people that might already need assessment, but don't have the ability to gain access to that. And we do those pro bono cases. But for each pro bono client, we still do the regular battery from start to end, and we do about 5, 6 to 10 of those every year just to give a bit of give back. So that's
Got it.
another option that's available too.
Sounds good. So yeah, just check in with the front office and see what options are available when you're calling
Mhm.
in. And where's your clinic? Where do they find you?
So we are in Minneapolis. We're literally overlooking Loring Park. Like when I look up right now, I'm literally looking over the park right now.
Awesome.
Yep. So yep, that's where we're at. And parking is paid parking, so you have to pay. But street parking, there's always a lot of options available.
Okay,
And
good
I think
stuff.
it is paid parking, but there's some options that are available for 2 to 3 hours for free parking. So
Okay, good.
yeah.
That would be helpful. And
Mhm.
then I will go ahead and list all of the website information as well at the notes section of the podcast so that everybody can kind of just click and check out a lot of those details on your website. I know for myself as a provider, I've read through your website multiple times to make sure I have all the information and
Mhm.
you know, because a lot of times you'll find a clinic and that information isn't posted. And so I
Mhm.
like that I can go ahead and share that with potential clients too. So
Absolutely.
it's a great place.
Mhm.
And so I'm curious. We had talked about some additional information that you want to kind of provide to some people. So, is there any resources that besides the book that we've already talked about a little bit
Mhm.
that you want to talk about, and or we talked a little bit about what you call the Barnum effect?
Okay, so I think with resources, there Attitude Mag. So it's a magazine that provides some really, really good evidence-based information on ADHD. So it covers the whole gamut for like nutrition. But what we like about, apparently what we really, really like that website is that all of the information that's posted is actually reviewed by doctors, psychologists, psychiatrists, researchers, educators. So it tends to be more evidence-based.
Oh,
So
wonderful.
most things that gets posted is verified. So that can be a really, really good one-stop shop for ADHD. So for those that works with autism spectrum disorders, it's almost like Autism Speak, the website.
Oh, yeah.
So Attitude is something similar that has like that one-stop shop for everything.
Awesome. I will go ahead and list both of those as well. So if you're
Mm-hmm.
looking for that information, please take a
Mm-hmm.
look below.
Absolutely. And then with the Barnum effect, what we're seeing is that with the rise of social media, TikTok, YouTube, Instagram, Snapchat, what we're seeing is that it's really, really impacting the work we do because it provides a community, but it also provides a lot of information.
Yes.
But what we're seeing from the research is that the information being provided is actually very, very inaccurate.
Right. This is what we see in our field, right? People coming
Yes,
through the
yes.
door. I have this
Uh-huh.
diagnosis because TikTok told me so.
Mm-hmm. So the Barnum effect is that when people provide information for a large group of people, um they tend to provide general and very broad information. But what happens is that the average person looking at that broad information will be able to identify with two or three different symptoms from a list of 30, right? And that person says, "Ooh, this speaks to me. This is exactly who I am." And that person then starts to believe it. But what this also does is that social media creates a community. So
Yeah.
then people feel attached and connected to the community, and then they come in to do testing, and then you then have to tell this person, no, it's actually not ADHD. You're okay, right?
Right.
Yes, you have some symptoms, or it might be something else. It can be very, very difficult for people to accept that at times because they have attached their identity to that, and they have actually used some interventions that have been really, really helpful. And I think as a field, this is something we need to be more mindful of, and it's going to
Yes.
continue to be impactful with the growth of technology and social media and all of that. So yeah.
Yeah, I think about that all the time of when you're on social media, and like it'd be like listening to this podcast and going, oh, they talked about the holidays might be stressful when you have ADHD, therefore I
Yeah.
have ADHD.
Yes.
Right.
Yes. Definitely have ADHD. Not right. Yep.
And some of the resources that we provided could be helpful for anybody dealing with
Mm-hmm.
any sort of stress. But it
Mm-hmm.
doesn't mean that because those things are helpful that you therefore meet criteria for a
Mm-hmm.
DSM diagnosis.
Right. Right. And when we look at medication, if anybody took a stimulant medication that was not prescribed, they will still see at least a 10% bump in their attention focus and concentration, just overall, ADHD or not, right?
Yes.
So what does that say? Even with using some evidence-based intervention, even if you're not diagnosed, if you don't have a diagnosis, you will still see an improvement in your overall functioning. So then what people say is that, oh, see, I did notice that. Yeah, you did notice that, but it doesn't necessarily mean that you meet diagnostic criteria for that. So,
Right. It's different. And
Mhm.
it also doesn't mean that you should, stop doing things that are helpful.
Right, no, you can still continue to do that. And that's the reason why even if we don't give a person a diagnosis,
Yeah.
we'll still say, yeah, things that you can still do to be able to lead a healthy life, to be able to help you function, to be able to help you just to be at your most optimal level of functioning.
It just might not be stimulants.
Yes, it just might not be that.
Right. And there are other wonderful tools and community out there. I think that is a big piece, right? We need community, and we need people that are supportive, and this is a way that people are getting that. So it's not a bad thing. Be careful of.
It's just be mindful of it, right?
Yeah.
And even when it comes to treatment, and that's the reason why we're not just focusing on medication, we're focusing on nutrition, we're focusing on physical health, we're focusing on environmental adjustment, we're focusing on cognitive strategies, we're focusing on emotional regulation strategies, because collectively, all of that really, really helps.
It does. It is not just a one thing. It's so many things together that make a big difference. I love that. All right. I want to end with one more quick question for you. What is a self-care practice that you incorporate in your own life that tends to be helpful?
That's a really, really good question. I think of vast majority of times when we think about self-care, there tends to be a lot of rigidity around that. But in my work with clients and in my individual life, the way I see self-care is about integrating small, doable tasks or steps into your life. So for me, what I do is that my wife usually reminds me every hour to stand and to walk for 1 minute.
Yes.
So I do that 12 times every day. And what this does is that on average, I'm getting 12 minutes of physical movement where I can also practice my breathing and calming myself down. And that's something I've integrated into my life, but it is such a small little step. But if I look at the cumulative impact within a day, I'm getting 12 to 15 minutes of physical movement. And that's how I try to build self-care into my everyday life. So I think in our work with clients, when we think about self-care, it doesn't have to be this massive or fearful thing. It can be these small, incremental little steps. And it's really, really difficult to change old habits because we have done them over and over and over, and our brain is really, really good. It's so easy. So trying to change that is going to take some practical baby steps. So
baby steps. Self-care equals baby steps.
Yeah, baby steps. And repetition, right?
Yeah.
Over and over and over. And then over time, it becomes more secondary.
Yeah, that is a wonderful thing to incorporate in your life. I agree with that wholeheartedly. Neurologically, it makes so much sense. And that physical aspect, like you talked about, self-care isn't always about going to the spa, right? Yes. Self-care is small little things over time. Oftentimes it's movement and attuning to your body.
Yep.
Something that we tend to overlook and move away from throughout the day when we're busy.
Yeah. And then just pairing this. So when I walk, I also try to take deep breaths. So I'm combining two different coping strategies together, right?
Yeah. Physical
movement and then mindfully calming my body down.
Huge resource.
Yes. Yeah.
Thank you for sharing.
Absolutely.
Well, thanks everyone for listening. I'm so thrilled to get this information about Calm out there. And if you need any more things, please reach out to their website. I'm thrilled to get Dr. Tamba's information out there for everybody. Thank you for joining me.
Absolutely. And you also have my email address. I gave you permission to provide if people have questions about research, about interventions and stuff, they can also reach out to me directly. I'm working on responding to my emails, so that's my growth edge, but I will try to get back to you as quickly as possible.
That's very brave of you, and I thank you for that. And so for anyone listening, a little bit of grace for those, it's one person. But yes, I will go ahead and post that information as well for a direct email because you are a wealth of information. I really appreciate it.
Yep.
All right, guys, this is the legal stuff, the disclaimer. The podcast is intended for educational purposes only. The information provided is not a substitute for professional therapeutic advice or counseling. Always consult with a qualified mental health professional for any personal concerns or issues. The views expressed on this podcast are those of the host and guest and do not represent the views of any affiliated institution or organization. Listener discretion is advised.